No chairpersons? All right. So this is a talk without chairpersons. I had a liberty to talk as much as I can. Thanks, organizer, again. So I will keep on moving from this to that hall. Now, after Dr. Kalra's talk on age-old medications, I'm back with sulphonylurea. As you can see, the topic is, where does sulphonylurea fits now in 2020, especially in the light of Carolina trial? I'm sure you are aware what was the Carolina trial. Carolina trial was a trial which compared glimepiride head-on to linagliptin and to look for cardiovascular outcome in the form of composite of 3-point mesh. And there was no difference between linagliptin and glimepiride. Why we looked for this Carolina trial was perhaps we waited for almost 3 decades with sulphonylurea. The first trial started with sulphonylurea was called Ugdp Trial way back in 1969-70, when the first generation of sulphonylurea, tolbutamide, was associated with increase in cardiovascular death. You can see this is very small trial, not more than 400 patients in this particular trial. Actually, this trial was not planned to see the cardiovascular mortality. This trial was just to see how sulphonylurea is an effective blood glucose lowering drug. However, during the trial, investigators found that in tolbutamide arm, there was increase in cardiovascular death. And since 1970 till the Carolina trial, we had to wait, so 3 decades, 30 years, to understand whether sulphonylurea is a cardiotoxic drug. And please remember, after this Ugdp trial in 1969, I was not born at that point of time, whenever you open the sulphonylurea's prescribing information, you will see this written that this drug causes increase in cardiovascular death. And from the tolbutamide, this PA extended to all sulphonylurea, starting from glibenclamide to glipizide to glimepiride and gliclazide. But it was amazing to know that a drug, tolbutamide, caused increase in cardiovascular death. So one son from a father was a terrorist, but unfortunately, all the son of that father was claimed as a terrorist later on. That was most unfortunate part in the sulphonylurea story. However, if you look back, other randomized controlled trial barring Ugdp, the big trial starting from UKPDS to ADOPT to ADVANCE to RECORD, they didn't find any signal of increase in cardiovascular death. But please remember, neither this trial was planned to look for the cardiovascular event. Barring the last two, which is the TOSCA-IT and the Carolina, which was primarily a cardiovascular outcome trial of sulphonylurea, the other trials, randomized controlled trial, which used sulphonylurea, didn't find any increase in cardiovascular death except in the Ugdp in 1969-1970. Still, for last 30 years, the SU has to carry the tag of increase in cardiovascular death for the sulphonylurea. For the observational studies, there are a lot of issues. Although RCT, barring Ugdp, did not find any increase in cardiovascular event with sulphonylurea, but then, as I said, these were not a cardiovascular outcome trial. UKPDS was a conventional versus intensive glucose control. So was the ADVANCE, ACCORD, and BADT, where sulphonylurea was used. It was not a cardiovascular trial. However, in the observational studies and their meta-analysis, almost all of those observational data suggested that sulphonylurea is associated with increase in cardiovascular death, basically reciprocating the finding from the Ugdp trial. And we were in a great mess till the Carolina trial result came out, and the TOSCA-IT also, which helped us to understand whether sulphonylurea has any potential to cause increase in cardiovascular event. But please remember, the observational studies itself has got a lot of issues, and in this paper, I'm not going to read what are the issues in observational study which suggested increase in cardiovascular event with sulphonylurea. As you can see, almost all observational studies had some kind of biases we call as a exposure misclassification bias, time lag bias, selection bias, etc., etc. So the observational studies can give you a hypothesis, but not the conclusion, because there are a lot of biases associated with observational studies. Nevertheless, It varied also with the sulphonylurea. Now, as I said, the tolbutamide showed increase in cardiovascular death, but this, terrible prescribing information or black box warning was given to all sulphonylurea since the Ugdp trial, including chlorpropamide, glibenclamide, glipizide, glimepiride, and gliclazide. However, if you look into these sulphonylurea, as I'm just trying to make an analogy, a father has got 4 sons in the form of glibenclamide, gliclazide, glimepiride, and glipizide. We also saw that there are differential outcome in the class of sulphonylurea with a different agent. As you remember, the Yudhishthir was different from Arjuna, and Bhim was absolutely different from Nakul and Sadeva. So you have got 5 brothers, but each of them has got a different characteristics. But unfortunately, they were clubbed together as Pandavas. Similarly, in case of sulphonylurea, in the Ugdp tolbutamide shows the signal, but in the entire class was blamed. So when we looked into the data of different sulphonylurea, and this paper was also shown by Dr. Kalra just now, there was interesting findings which was happened with the different sulphonylurea. As you can see in this paper, keeping metformin as a cardiovascular neutral drug, if you compare, and remember this is observational, this is a Danish registry, which interestingly find that if you keep metformin as a cardiovascular neutral drug, you do find a different kind of CB outcomes with different sulphonylurea. And you can see the one agent which is absolutely damn neutral, barring repaglinide, which Dr. Kalra talked. I'm talking about sulphonylurea. The gliclazide stands absolutely in between, whether it's total death, whether it is cardiovascular death, whether it is MI stroke or cardiovascular death. You find the gliclazide is looking different. The Arjuna is looking different from the other brothers. You can see glibenclamide, glipizide, and tolbutamide do have some kind of signals. Glimepiride has got little bit confusing data in that sense on the different CB endpoint. The another meta-analysis by Simpson and team, and this is European data, also again you actually supported the previous finding from Danish registry, and now you can see keeping glibenclamide as a reference. If you feel that glibenclamide has a potential of increasing cardiovascular event, if you compare other 3 brothers like glipizide, glimepiride, and gliclazide, you can clearly make out that gliclazide seems to be completely different compared to other, other previous sulphonylurea like glipizide and glimepiride. So that was interesting finding happened. And you can see here, in all-cause mortality, glimepiride was also not showing any signals in increase, and similarly on the cardiovascular. So the gliclazide outstanding absolutely neutral in terms of CB death or all-cause mortality, and glimepiride next followed immediately. We also did a systematic reviews of all the sulphonylurea trials. You can see the 4 years back. Actually, I was looking what is the difference between glimepiride and gliclazide. Finally, I came out with a completely different data. I was forced to believe that gliclazide is completely different molecule, even better than glimepiride, as far as the CB event and renal event is concerned. And I would like to point out to you on one study where the glimepiride was head-on compared with gliclazide on renal endpoint in an elderly population consisting of more than 3,000 patients. Clearly, the gliclazide outscores glimepiride on the renal endpoint, perhaps believing that gliclazide may have some renal protection potential compared to glimepiride, as we experienced in the advanced trial in the form of randomized controlled trial. However, because this is a busy slide, so I thought to summarize you what we found in our systematic reviews, that the best mortality outcome data lies with gliclazide followed by glimepiride. Actually, we worked hard to understand sulphonylurea prior to the Tosca-IT and Carolina trial, because we had nothing in hand since 1970 after the Ugdp. One thing we learned that glibenclamide has a worst outcome. It caused highest hypoglycemia and very severe, and it has eventually been thrown into dustbin. And glipizide has somewhere intermediate risk as far as the CB mortality is concerned. Now, when you finally land down to 2 sulphonylurea, which is glimepiride and gliclazide, now we need to understand between these 2 sulphonylurea and their difference. As far as the glucose reduction is concerned, I would say that both are equal. I mean, there are studies, head-on studies For example, this study is called GUIDE study, and this is the only head-to-head randomized controlled trial available in the planet where you can compare SU versus SU. Other all trials are observational study, and that's why it's subject to use bias, and I don't wish to even see those studies. So you need to make to understand a comparison between A and B, you need to have a double-blinded randomized controlled trial, and this is the only study which compared glimepiride to gliclazide head-on. And now you can see there was no difference in the glucose control in your left-hand side. In HbA1c, both were similar. But what you can make a differentiation between two molecules, that there is a 50% less hypoglycemia with gliclazide MR in the GUIDE trial compared to glimepiride. This was an outstanding study basically suggesting that the gliclazide is one sulphonylurea which causes least hypoglycemia in the class. And that you can understand from this meta-analysis which we did in 2016. We tried to compare the hypoglycemia outcome between sulphonylurea and DPP-4 inhibitor, knowing that the DPP-4 inhibitor per se will not cause hypoglycemia. So we looked for a randomized controlled trial during Ramadan to understand which SU or DPP-4 has a potential to cause hypoglycemia. It would be amazing to know in these three RCT, you find out this is, the red one is gliclazide, is as good as a DPP-4 inhibitor. And seen one of the trials, this was by our own Arvind from Bangalore, clearly suggesting that the gliclazide is one sulphonylurea which has the least potential to cause hypoglycemia, even in a special situation like during Ramadan, and it is as good as a DPP-4 inhibitor in terms of hypoglycemia. So you have got a randomized controlled trial in the form of GUIDE, and now you have got a RCT evidence during Ramadan which suggests that clearly gliclazide, glibenclamide has got a highest, immediately followed by glimepiride, and then the list with gliclazide equal to DPP-4 inhibitor. So that is about the hypoglycemia. What about the outcomes? So when you talk about gliclazide, we have got a trial called ADVANCE trial. This was not exactly a gliclazide trial. This was basically an intensive versus conventional arm trial. So ADVANCE, but it used gliclazide, exclusively in the intensive arm compared to the conventional arm. And you can see there in the primary outcome was the composite of both macro and microvascular endpoint. There was 10% reduction in the composite of macro and micro together. But on individual endpoint on micro and macro, there was no significant reduction. And this was primarily derived from improvement in albuminuria in the nephropathy outcomes with the intensive, in the intensive arm, which was primarily the gliclazide-based arm. As you can see from the different outcome, the benefit was happened in the primary composite endpoint, which was a combination of major macro and microvascular endpoint. But this was primarily derived from new or worsening nephropathy with gliclazide. You can see there was 21% reduction in the intensive gliclazide arm compared to the conventional arm. But there was a catch that even in the conventional arm, 57% patients were receiving other sulphonylurea in the ADVANCE trial. Ideally, if you are comparing gliclazide to other sulphonylurea, in the other arm there should not have been any sulphonylurea. So that was the caveat in the ADVANCE trial when you are trying to understand gliclazide through the ADVANCE. Nevertheless, the intensive arm did find a significant reduction in the nephropathy in the ADVANCE trial. And no wonder after these trials, if you see the guidelines across the world, NICE UK took gliclazide, omitted glibenclamide from their essential list of medications. The Dutch guidelines in 2013 said the gliclazide should be the second-line drug after the metformin. WHO included gliclazide in their essential list of medications, as you can see in 2013. And the latest Canadian guidelines said that if you're using sulphonylurea, prefer gliclazide. And that's what we find in our systematic reviews and meta-analysis. However, since the publication in 2008, as I said, the ADVANCE was not exactly the trial which we're looking for. We're looking for a CB outcome trial. And we had to wait for so many years since 1970 Ugdp to look for the CB outcome trial. So the two trials we waited for was the Tosca-IT. It is Italian study, and the Carolina trial, which is a multi-continental trial. So what happened in the Tosca-IT trial? The Tosca-IT trial actually compared sulphonylurea to pioglitazone. And the sulphonylurea was primarily glimepiride and gliclazide, 50% each in the sulphonylurea arm. and that was compared to pioglitazone. So it's not a placebo-controlled trial, it's an active controlled trial. So it's again different from the original kind of cardiovascular outcome trial where the placebo should be compared to understand. It's an active comparator trial. However, this was a trial in the sense interesting was because earlier we had a feeling that pioglitazone is of course better than sulphonylurea as far as CB outcome is concerned. We learned it through the Periscope trial. We learned it through the Chicago trial that there was a significant reduction in intima media thickness and coronary ultrasound measurement with the pioglitazone compared to sulphonylurea. But these were mechanistic study. This study, we thought that perhaps pioglitazone will beat sulphonylurea because we had a feeling that this drug has a potential to increase cardiovascular risk. But interestingly, in this trial, even pioglitazone could not beat sulphonylurea on the CB outcome. As you can see here, there was a 4-point mesh which included all-cause death in place of cardiovascular death, and the unstable angina was one of the 4th endpoint in the TOSCA-IT trial. And this BG slide suffice to suggest that there was no difference between sulphonylurea and pioglitazone in TOSCA-IT. So naturally, finally, we waited for this trial called Carolina, which compared glimepiride to linagliptin, a DPP-4 inhibitor. Almost 50% of the patients in Carolina had established heart disease. And this trial was a pretty long trial. So if you see any DPP-4 trial or any GLP-1 trial, any GLT2 trial, this is the longest CB outcome trial comparing sulphonylurea to glimepiride with a median duration of 6.2 years. And it was again, it was not a placebo-controlled trial, it was comparing glimepiride to linagliptin. And what happened? We thought something else, but the result came completely different. And there was no difference between linagliptin and glimepiride in this cardiovascular outcome trial called Carolina. We all were amazed to know that, well, we have got a drug, glimepiride, which we are using for last 50 years, sulphonylurea, and yet there is no signals in increase in cardiovascular risk, which was raised in 1970 from the Ugdp. So we actually had a great satisfaction to understand that the drug which we used in past is no longer cardiotoxic, which was, we were forced to believe that there is a potential to increase in cardiovascular toxicity. But then the Carolina was the game changer for the sulphonylurea, in particular for the glimepiride. However, if you closely look into this data and deep dive into everything was neutral. But one thing strikes me in the Carolina trial was there was trend of increase in heart failure hospitalization with linagliptin. It was amazing to know. We thought that glimepiride may have some kind of trend, but it was just opposite. There was increase in the heart failure hospitalization, and if you take HHF or heart failure death, there was somewhere trends, although it wasn't statistically significant. But then this is, bad enough to know that here you have got a molecule DPP-4 considered to be the safest one, has got some kind of trend in increase in heart failure or heart failure related death compared to a glimepiride, which was supposed to be cardiotoxic. So that was the biggest message from this trial, which suggested that sulphonylurea is absolutely cardiovascular friendly drug. However, there was a significant increase in hypoglycemia, as you can see here, although the severe hypoglycemia wasn't that bad. So if you see the Carolina's implication in current context, also one thing we learned, we were forced to believe that sulphonylurea fails early. There is very high secondary, OHA failure with sulphonylurea. See, in the Carolina trial, both glimepiride and linagliptin had a similar glucose control up to 6 years. We have been given this idea that sulphonylurea failed by 3 years. It came from ADOPT trial comparing glibenclamide to metformin and rosiglitazone. It came from the RECORD trial, again comparing glibenclamide. Glimepiride is absolutely different. And you can see here, the glimepiride is giving you result of glucose control similar to linagliptin, even up to 6.2 years. So the first idea which we learned from Carolina, barring the CB safety, that this drug lowers blood glucose sustainably up to 6 years like a DPP-4 inhibitor. Second one, although there was increase in hypoglycemia by 3-fold in the initial phase, but if you see the severe hypoglycemia, it was similar, almost similar between two arms, but at the cost of trend of increase in heart failure with linagliptin compared to glimepiride. So what I understood, that yes, glimepiride can cause hypoglycemia, 25 more with glimepiride, so there was 27 hypo versus 2. Although linagliptin will also cause increase in heart failure by 20. Now you take a balance. Which one is more harmful, a severe hypoglycemia versus, not severe, means overall hypoglycemia versus a heart failure. Now, so finally we landed with 3 trials, which is the CB outcome trials with different sulphonylurea, Advanced, Tosca IT, and Carolina. These are, I'm not going to read because of paucity of time, but you can see here what happened is primarily that there was no difference between both the arm in these 3 trials. Barring that in the Advanced, which was the gliclazide-based trial, the primary outcome was met, which was the composite of both micro and macro, and it was primarily derived from the renal benefit. You can see here 21% reduction in nephropathy with the gliclazide arm in the Advanced trial. The rest of the trial suggesting no difference, barring suggested there was increase in heart failure with pioglitazone in Tosca IT, and there was a trend of heart failure with linagliptin in the Carolina trial. Well then, so what we understood through these trials, we have got glimepiride, which shows CB neutrality in the Carolina trial. So all controversy related to sulphonylurea safety as far as cardiovascular safety is concerned has been put to rest. This trial also shows that glimepiride is as good as linagliptin in controlling blood glucose up to median 6.3 years. However, hypo with SUs is always well known, but the good thing was the severe hypo was not that bad with glimepiride compared to the linagliptin. The only double-blind randomized controlled trial was the guide which compared glimepiride to gliclazide, shown similar glucose control, but the hypo was 50% less with gliclazide preparation compared to glimepiride. The 2 meta-analyses of observational studies, which I have shown you from Scram and Simpson, showed among the sulphonylurea, the gliclazide has got least CB mortality compared to all other sulphonylurea. And in Advanced, which was primarily a gliclazide MR-based study, there was a significant reduction in nephropathy, which wasn't seen in any of the trial as of now compared or done with sulphonylurea. So to me, both gliclazide and glimepiride appears to be cardiovascular neutral drug. In CB safety, I will give glimepiride little bit S because of the Carolina trial. But in terms of hypoglycemia, weight gain, I will give gliclazide much more S over to glimepiride, as I suggested from these data. Thank you very much for your patience listening.
Thank you, Dr.
No issues, please.